Hello, is it Irene? I don't have my glasses on. Arlene? Is it Arlene? I don't have my glasses on. Kind of helps, right? All right, it is 6:05. We're going to go ahead and get started. Hey, hello everyone. My name is Roxana Rabati, the Community Health Supervisor at San Antonio Regional Hospital, and I will be moderating today's virtual lecture. I want to thank you all for participating and attending into this evening's lecture, Don't Shoulder the Pain, New Advances in Shoulder Injuries and Replacement, presented by Dr. Connor LaRose. A few housekeeping rules to keep in mind. Please hold all questions until the end of the presentation. Use the Q&A chat button, not the chat button, for any questions. And this session is live streamed on Facebook, Twitter, and YouTube, and is also being recorded. With me today is Kathleen Webster, and she will be also monitoring the Q&A, and she will be answering any questions that you guys kind of ask in that. Any other questions will be addressed by Dr. LaRose. Kathleen, can you please take it from here?
Absolutely. Hi, and welcome for me as well. And my name is Kathleen Webster. I am San Antonio Regional Hospital's orthopedic nurse navigator. And before I introduce you to Dr. LaRose, I'd like to highlight a few things about our award-winning joint replacement center here at the hospital. We perform over 500 total hip and knee replacement procedures each year. We have a dedicated orthopedic nursing unit for total joint replacement patients, all with private rooms. Our patient satisfaction scores exceed the top 10 percentile in the nation. We have consistently achieved the Joint Commission's advanced certification in total hip and knee replacement since 2017. And much of our success can be attributed to our nursing staff, our physical therapists, and of course, our orthopedic surgeons, such as Dr. Connor LaRose. Dr. LaRose is a fellowship-trained orthopedic surgeon specializing in sports medicine, and he is affiliated with Arrowhead Orthopedics. He has expertise in comprehensive shoulder surgery, as well as arthroscopic surgery of the shoulder, knee, and hip. He also has vast experience in fracture care of pediatric and adult patients. He was born and raised in Claremont, California, and continues to reside there with his family. He earned his bachelor's degree from the University of Notre Dame, where he also played 4 years of soccer. He continued on to obtain his medical degree from the University of Cincinnati College of Medicine and completed his orthopedic surgery training at Duke University Medical Center. In addition to completing one of the top orthopedic residency training programs in the country, he helped provide medical coverage for the Duke University sports teams, including the basketball and football teams. Dr. LaRose's clinical interests include injuries involving the shoulder, hip, knee, and ankle. He is certified by the American Board of Orthopedic Surgery and is currently a member of the American Orthopedic Society for Sports Medicine, the Arthroscopic Association of North America, the International Cartilage Repair Society, and the American Academy of Orthopedic Surgeons. Dr. LaRose is an assistant clinical professor associated with Loma Linda University, and he's involved in teaching and training their orthopedic residents at Arrowhead Regional Medical Center. Dr. LaRose remains active himself, spending his free time running, golfing, and playing soccer. And I would encourage you to read Dr. LaRose's bio on the San Antonio Regional Hospital website for more details of his wealth of experience and accomplishments. And it is now my pleasure to introduce to you Dr. Connor LaRose.
Okay, thank you, Kathleen. That was a very nice introduction. Can you guys hear me okay?
Yes, we can.
Perfect. Can you see me or?
You're perfect. You're right
Perfect.
there. You can see everything.
Okay. Well, Kathleen, thank you so much for that introduction. And let me just kind of echo some of the things she said about the joints program at San Antonio. through a lot of hard work and effort from the nurses, the administration, physical therapy, the OR staff, and the surgeons, we put together a great joints program for our patients, doing a lot of total hips and total knees, and also doing a lot of total shoulders with really high success rates. So it's really a fabulous place. Feel very comfortable sending my patients to San Antonio for these procedures. I know they're going to be treated well, treated with the best possible care. And so definitely happy to support this lecture series. We're going to talk today about shoulders and shoulder arthritis and how we treat that as orthopedic surgeons and our approaches to our patients. And we'll go into some of the details. Some of it may be a little bit more detailed than you want to see, but I think a lot of you guys will find it interesting. And then certainly, I think there'll be some time for me to answer some of your guys' questions that come up in regards to, the shoulder and anything else that you guys want to talk about. So let me share my screen here. We'll get started on the talk, and then we'll proceed from there. Okay, guys? Okay, you guys see my screen okay?
Yes, perfectly.
Perfect. Okay. All right. So as we often do when we give these talks, we'll start actually with a case presentation. So this is actually a case of mine from several years ago, and it'll kind of give you a kind of full example, gamut of kind of what we see as orthopedic surgeons. But this was a 65-year-old male who had a prior fracture to his top of his humerus. That's right. That's the bone that's part of the shoulder joint. He had this fixed with a plate and screws, and things went well. But unfortunately, he ended up developing arthritis in that shoulder joint. And so we'll show you his x-rays here. So you can see here the two x-rays of the shoulder with the metal plate and screws, is that white stuff there. And while the fracture healed, unfortunately, the shoulder went on to arthritis. And so he continued to have pain. And so what we did with this is that we converted him from this fracture construct to what we see here, which is what a standard shoulder replacement looks like, with the metal prosthesis, which is the white thing down the humerus. And then what you can't see or can't see very well is that there's a prosthesis on the glenoid side. That's the resurfacing of the glenoid. So we'll go into some of the anatomy and the details so you guys will have a little bit of understanding. But this is a pretty complicated patient who kind of had two big surgeries, but did well and was very happy with the shoulder function and pain afterwards. So, all right, so we're going to dive into the topic, shoulder arthritis and then shoulder arthroplasty. And as Kathleen mentioned, my name is Dr. LaRose. I'm one of the surgeons over at San Antonio. I'm with the group Arrowhead Orthopedics, which we have offices kind of all over the place. But in this local community, one in Rancho and Chino Hills. And like Kathleen said, I see a lot of sports medicine, a lot of focus in shoulder, from arthroscopic procedures to the open procedures that we're going to talk about today. And we have lots of other surgeons who do specialization in hip and knee, and you'll probably hear some of those talks later in the community lecture series as well. So just getting to the numbers here, just to kind of give you guys a perspective of kind of how we see, or what we see as surgeons, and the number of surgeries that we've done. This data is it's a little data, it's 10 years old now, but we can see at the top here, total knee replacements and total hip replacements. That's a whole lot of big numbers. We come down to our total shoulder replacements down here. It's a magnitude less than what we're seeing in total shoulders, or total hip and total knee replacements. And that's true if you look at the numbers at San Antonio. We do a lot more hip and knee replacements, but I will tell you that we're certainly addressing shoulder replacements more and more commonly now. And this number over the next 10 years, and when I get that data, I'll update the slide, will really reflect that there's been an increase in the volume of shoulder replacements regionally at San Antonio and then across the country. We've gotten better techniques, and certainly shoulder replacements outcomes are really good. Patients who need it really do well with it. We'll go into this slide here. This is for little details here, but there's two types of shoulder replacements, which we'll delve into a little bit. I'll explain a little bit more about that. And one is the standard, or what we'll call the anatomic shoulder replacement, and the other is what we'll call the reverse shoulder replacement. And we do about 50% of standard shoulder replacement and reverse shoulder replacement. That decision is based on the kind of the pathology of the shoulder and the things that we're treating. And so I'll talk a little bit more about that, give you guys a little bit more information. So if you guys unfortunately are in our office and need to have a discussion about that, you'll maybe have a little bit of understanding of what the difference is and why we pick one type of prosthesis or one type of procedure versus the other. All right, so here is our anatomy lecture here, and where you guys are all become anatomists at the end of this. So these are just a cartoon drawing of what a shoulder joint is, and the shoulder joint's pretty complicated, but to kind of bring it down to its basic function, the main shoulder joint is a ball and socket joint, and you can see my little cursor going over here. This is the humerus, or we'll call the humeral head, and then this is the socket, or we'll call the glenoid. Now the glenoid is attached to that wing blade. That's that big bone that we can kind of all palpate or feel on the back of our shoulders. That's called the scapula, and at the kind of the end of that scapula is the socket part of our shoulder joint. We also know the clavicle, which is that collarbone in the front, and it attaches to a bone on top of there. That kind of is the shield, or the kind of covers the shoulder joint. But the main shoulder joint, and the concept that you guys should kind of understand is that, and the way we think about the shoulder is as a ball and socket joint. And so we can see those, the head of the humerus and the glenoid. Those are two main aspects that make up the joint. So when we talk about shoulder arthritis, what is it that we're actually talking about? Well, it's the loss of the cartilage. The cartilage is that smooth white stuff that caps all the bones in every one of our joints in the body. So whether it's your small joints in your hand, your hip joint, your shoulder joint, the cartilage is that stuff that allows those joints to move smoothly without pain. When we lose that cartilage, and we can lose it for multiple different reasons, we'll talk about a few of those in the next slide or two. But basically, when we say arthritis, when we tell our patients you have shoulder arthritis, is that you've lost that cartilage in the joint. And so once you lose that cartilage in a joint, that's when we start seeing the pain from arthritis. And then we start to have to talk about our treatment options in regards to that. So there's lots of different causes of arthritis. So these are the etiologies. You oftentimes will hear this first one called osteoarthritis. That's kind of the catch-all term for arthritis. Osteoarthritis, there isn't one specific cause of it. It's what we call multifactorial. There's a lot of genetics associated with it, but it can be related to lifestyle, genetics, environment, things you did as a kid growing up. A whole litany of things can cause and lead to this osteoarthritis. And that's the most common arthritis that we see in most of our patients for shoulder, hip, and knee. Okay. There's other ones we talk about. So inflammatory arthritis, and most people have heard of rheumatoid or lupus or Crohn's disease. They can lead to what we'll call an inflammatory arthritis. So that's the loss of the cartilage as it relates to this inflammatory process. As we saw in our case presentation, fractures can lead to arthritis down the road, and sometimes we'll have to do arthroplasty for those. There can be a thing called avascular necrosis. That's where you lose blood supply to the bone, and the bone dies, and you develop arthritis for that. We see that very commonly or frequently in our hips. And so these are kind of the major etiologies that we see as far as why someone would develop arthritis in their life. Okay, so these are some of the x-rays that we'll see. So this is once again a front-facing view. The humerus is this bone here. The glenoid is this bone here. And this is a patient with moderate shoulder arthritis. What do I mean by that? Well, they have loss of joint space between the two bones. We oftentimes will see bone spur down here. It's the technical term, we call that as an osteophyte, but it can be more commonly referred to as like a bone spur. And that's very common we see with arthritis, and throughout the entire body, the body likes to form these bone spurs as part of the arthritic condition. This is another picture. This humeral head here, seeing lost its kind of roundness that we normally would see. This is an AVN patient, so they've lost the blood supply to that humeral head for various reasons, and they get this flattening of the humeral head, and then you get this osteophyte and arthritis formation. Here's a patient that has a specific type of arthritis. This is called a cuff tear arthropathy. And this is basically the loss of the joint space. But then we notice here, I'll flip back to this prior view, there's a space that exists between this bone up here and here. Well, that's where your rotator cuff tendons attach, okay? And when we have normal rotator cuff tendons, it keeps those two bones apart. If we looked at this picture here, all of a sudden we see, there's really no space between these two bones. And so not only does this patient have arthritis, so loss of that cartilage, they've also lost that space, which means you also have a large rotator cuff tear as well. So this requires that special treatment. This is going to require that special prosthesis called the reverse shoulder replacement, which I'll show you pictures of soon. Here's someone who's had a really bad fracture. So here the head piece is here, the big piece here. Pretty common fracture we'll call proximal humerus fracture. We'll see these very commonly in our little bit older population. They have falls at home. These oftentimes will require or need an arthroplasty to fix them. Here's kind of some special conditions. It's a neuropathic joint. So patients who have neuropathy will sometimes develop these really bad looking shoulders that really are difficult to treat. We oftentimes will not do surgery on these because they don't do well with any type of surgery. All right, so before we jump into kind of our surgical solutions, we always want to talk about non-operative treatment first, and certainly in every discussion I have in my office with patients, when we talk about, and I say you have shoulder arthritis from osteoarthritis or inflammatory arthritis, we always want to talk about some non-operative treatment before we start talking about any big surgeries. So first thing we talk about, activity modification. If there's a certain thing that you are doing that seems to aggravate that shoulder and really is the problem, then we need to kind of modify our activities. And, that's frustrating for a lot of patients to hear, but in reality, it can sometimes be the thing that allows you to have a pain-free life. And if that's a simple thing to do that doesn't really bother you too much, then that's certainly something to consider. Anti-inflammatories like Motrin, Advil, these things work. We have to be careful. There are some side effects, GI side effects, kidney side effects, some heart-related side effects. So a lot of my patients I talk to, I'll say some NSAIDs, but we be judicious with it. If there's any issues or any contraindications, we want to stay away from it. Here you can see the picture of what's going on here. This is a glenohumeral joint injection. So we're doing a corticosteroid injection. So that's placing a corticosteroid into the shoulder joint itself. What does that do? Well, it's a strong localized anti-inflammatory. Arthritis, why does it hurt? Well, it hurts because it stimulates a lot of inflammation in the joint. And so the cortisone can be a good way to mitigate that, put it on pause for a little bit. It's not perfect. It doesn't relieve all the symptoms for a long period of time, but certainly is helpful in the short term. So 3 to 4 months. If it works really well, it can be repeated. If it doesn't work, then we sometimes move away from it. Physical therapy, limited role for physical therapy, especially in the shoulder. I find that a lot of patients who have pretty significant or advanced arthritis don't do well with physical therapy. They oftentimes feels like it aggravates them. If they have mild arthritis, certainly think physical therapy is helpful, but advanced arthritis is not going to be helpful for them. Hyaluronic acid or PRP injections. Hyaluronic acid is a joint lubricant. Is very commonly used in the knee. Hasn't really been authorized by insurance companies to be used for the shoulder, but occasionally we'll ask for it and we'll get it approved. It's certainly something that can be, once again, it's more going to temporize the cartilage pain from the arthritis. It certainly isn't going to get rid of the arthritis. PRP, that stands for platelet-rich plasma. I think you're going to hear a whole talk about biologics from Dr. Hussein, so I won't go into that too much, but this is basically where we take your blood, spin it down, and take the platelets out and inject those platelets into the joint. That's been shown in kind of multiple new studies coming out here in the next probably a couple of years to be beneficial, maybe have a little bit longer lasting pain relieving effect than our glenohumeral joint. Cortisone injections, once again, not a cure-all, not going to get rid of the arthritis. These are all temporizing measures, okay? All right, before we jump into surgery too, we also want to make sure we're doing the right surgery for the right patient, and there's nothing here that's going to prevent us from having a good outcome. So contraindications to doing a shoulder replacement. So here we have to look at the muscle function. So we have to make sure the deltoid, which is the big muscle that wraps around the shoulder, and the rotator cuff are working, especially the deltoid. If these two muscles are not working, they're not really a good candidate for a shoulder replacement. Clearly active infection anywhere inside the body, whether it's around the shoulder, a distant site at the foot, a toe abscess, anything, a tooth infection. These are things that absolutely have to be cleared up before we can consider any type of shoulder arthroplasty. This is the same with the hip and the knee. Really important because the number one complication we'll talk about is infection. We want to avoid this thing as best we possibly can. So we have to make sure there's no other active infections throughout the rest of the body, not just in the shoulder, everywhere else. Neuropathic, this is someone who doesn't have normal sensation to the arm. These patients don't do well. Their arthroplasties tend to fail very quickly and early, so we try not to do surgery on these patients. Intractable instability. So the shoulder joint is a pretty loose joint. It allows for a great range of motion. There are some patients who just have a shoulder just pops out in all different directions, is really, really unstable. These are patients that we are tough customers as far as treatment. The reverse shoulder replacement could potentially be a solution as it's more of a constraint, offers more stability than the standard shoulder replacement, but you have to be very careful with these patients. Non-compliant patients. So what do I mean by that? Well, certainly, when we do a shoulder replacement, this is a non-biological implant. So this is a metal prosthesis. This is a plastic liner in there. And so when I tell my patients, there are going to be some restrictions in regards to how to function with the shoulder. So if you're not compliant, meaning you're doing things that you shouldn't be doing, the prosthesis could get loose. We could see early failure. And so this could be very problematic for our patients in the future. So we have to be very clear about the kind of the post-operative instructions. I'll talk a little bit about that in the next slide. We'll go back to severe bone loss. So what does that mean? Well, in our patients who have a lot of severe arthritis in their shoulder joint, who've had it long standing, we see a lot of glenoid or bony deformities, makes the surgery very tough. We have a lot of different solutions nowadays, certainly a lot more than we had 10 years ago. So this is less of a concern as far as not being able to do surgery, but it is, we do have to address it. Sometimes we have to get a custom prosthesis, which is directly for the patient. So we have to be kind of cognizant of that. That's the job of the surgeon. That's what when I'm assessing patients, whether or not they get a CT scan or special prosthesis made, that's the job of the surgeon. Certainly it's a discussion I have with the patient. Young laborer. So these young patients with, I should just say young arthritis. So if you have a young patient who has bad arthritis, tough patient to treat, they're not really indicated for that shoulder arthroplasty because they will wear this thing out, it will get loose, it will fail, and we'll be having to redo it again, which is a really tough problem to solve sometimes. And that's what this kind of cartoon is here. On the right here, I have my 75-year-old patient who has shoulder arthritis, not demanding, not working heavy labor activities. This is the person who's going to do great with their shoulder arthroplasty. They're going to do wonderful. This guy over here, big muscular bodybuilder, lifting heavy weights, has shoulder arthritis, which we do see in this patient population. They're a really tough customer. They hurt, but they don't want to stop what they're doing. They want to keep lifting. They want to keep working. We have to kind of mitigate these. And we do all those other things we talked about, cortisone and hyaluronic acid, PRP injections, other types of non-arthroplasty or replacement surgeries are kind of what we discuss with these patients until they're at a time in their life where they understand and are willing to meet those restrictions. All right, so imaging studies in the office, when you see us, we're all going to get x-rays of the shoulder. The x-rays of the shoulders really help us diagnose the arthritis. So the arthritis, and these don't come up that well, but arthritis is basically that loss of that joint space. That's what we're looking for. If there's any significant bone loss, if I'm concerned about soft tissues, then I oftentimes will get MRI and CT follow-ups that will help give us more information about the understanding of this, what's going on in the shoulder joint. But to make the diagnosis, shoulder arthritis, plain film x-rays are really what you need. And this is just talking about a little bit of the bone loss. We have a classification for it, and these are things that we assess at the time of when you're in the office. How much bone loss do I need to account for this time of surgery? Do I need to get a CT scan to better evaluate it? Do I need to create a custom prosthesis for my patient? And this is kind of the thinking of as a surgeon we go into evaluating these patients, the kind of the next level stuff that you want to make sure that we're not missing. All right, so surgical treatments, we'll kind of go into all of these. I'll kind of show you little pictures of each one. So the first thing we're going to look at, this is just an arthroscopic picture. So does arthroscopy, where we put a small camera inside the shoulder joint, does it play a role in shoulder arthritis? It does play a role, a limited role, but there is good evidence to show that in a young, active individual who's got bad shoulder arthritis, who has a lot of pain, going in and debriding, removing some of the loose cartilage, labrum, taking care of some of the soft tissue things like the biceps can be beneficial for the short term, give you minimal but some substantial relief of symptoms. How long it lasts, most of the study shows only lasts from 2 to 5 years. But in a 40-year-old with bad shoulder arthritis is certainly something to entertain. It's not perfect by any stretch of the imagination, but in our young active patient that we're not quite ready to do a shoulder replacement on, it's certainly something to consider and something I will talk about with my patients and kind of go over some of the options and whether or not we think it's really warranted. These are a little more advanced type procedures. This is another arthroscopic surgery. So arthroscopic means we're putting a camera inside the joint. You can see where the humeral head is labeled. Below that, it says graft. So what is that? Well, that is, we've brought a cadaver graft in, and instead of putting a plastic prosthesis, we're actually put a graft over the top of the glenoid. Okay. Once again, this is only going to be indicated in a really young patient population, someone we're not quite ready to do a shoulder replacement on, but who's having significant pain from arthritis. These graft procedures, they're challenging. They take a long time to do. The success rate is variable. I'll be honest with you, not as good as a shoulder replacement as far as predictability of pain relief and long-term outcomes. But once again, in someone who's a tough customer, that young arthritis patient, certainly something you could consider doing. Once again, not as predictable as an outcome as a shoulder replacement. This is a more open version of that. So you can see here, this is an open incision here. This is the graft right down the middle. You can see it's sewn in. The glenoid is sitting behind that. And is basically trying to resurface that glenoid biologically with this graft. Once again, outcomes somewhat mixed depending on the literature that you read. Here's a picture of not a full shoulder replacement. This is what we call a resurfacing. So we've just removed the head and to replace the headpiece with this metal prosthesis. This could be used in someone who's got a focal chondral injury, so just the not complete arthritis, but has a focal area of arthritis. More and more of these are done for both global arthritis, but we don't do a lot of these. But this is something for certain patients that may be worthwhile. A younger patient, you're trying to preserve their bone, maybe consider this as an option. This is your kind of tried and true. This is what an anatomic total shoulder replacement looks like. So just to go over it again, remember our humerus is the humeral head as that ball. The socket is the glenoid. Here, the metal prosthesis is going down the middle of the humerus, and we've removed the head and placed it with this metal prosthesis that looks just like the normal head, except it's made out of metal, obviously. And here we can see there's a clear space here. Well, that's not air in there. That's a plastic liner that's attached to these pegs that we've drilled and implanted into the glenoid. So this is what a standard or an anatomic total shoulder looks like. Very predictable outcomes. Patients do great with these in the right circumstance. Here's a little bit of an odd character. This is what we call a CTA head. This is a patient who has arthritis, also has a massive cuff tear. And before we really got good with our reverse shoulders, our techniques, and our implants, this is what we would use for patients who had both arthritis and the loss of that rotator cuff function. It's called the CTA. Now we only use these in kind of the revision setting when everything else fails. They don't provide significant pain relief, and that's why we don't like them. But they are used still in kind of the last ditch or kind of the most severe type of failures that we see out there. This here is the reverse shoulder replacement. So remember the standard anatomic shoulder replacement, we've put the ball where the ball used to be. In the reverse shoulder replacement, we've switched them up. So now instead of having the ball on this side, we've reversed it and placed the ball on the glenoid side, and then the socket is here. And what you can't see is that it's a plastic socket, meaning that is where the articulation is. And like I said, there are some specific reasons we do a reverse shoulder replacement. We do them very commonly now. If we look at the data from the US, about 50% of all shoulder replacements that are done are going to be the reverse variety. Reason being is that it handles a lot of different variable outcomes for us: bone loss, rotator cuff issues, instability, revision setting, that these make it very easy for us to do. And so you'll see a lot of these being done in the US, and they have good outcomes as well. As far as the function is probably not as good as a standard shoulder replacement, but pain relief and improvement in function, usually these patients have very poor function preoperatively, so they do have improvement in their function, don't get it wrong. Not maybe as predictable as a standard total shoulder replacement, but from where they're at their baseline, it does improve their function, and certainly pain relief is very predictable. This is something you almost never will see. I've probably, in my 15 years of orthopedics, have seen one of these. This is a shoulder fusion. That's where we literally are plating the scapula and the glenoid and the humerus together, so there's no motion inside that shoulder. It really doesn't move at all. The scapula can still move, so these patients still have some function, but rarely do we ever see this. And like I said, it's been probably 10 years since I've seen one of these. All right, I'll quickly go through some of the surgical technique, as some of you might find this interesting. There's a little cartoon here. Most of us will do what we call an anterior approach. So when we talk about doing a shoulder replacement, we have to open up the shoulder joint. You're going to see an anterior incision. It's a fairly long one, depending on the pathology that we're treating, but it runs right down the front of the shoulder. Cosmetically, it's not too bad. But we have to kind of dissect. There's a nice kind of muscle plane that we go through. The muscles are represented here by this red stuff. This is the pectoralis major and the deltoid. Once again, you guys are all going to become anatomists at the end of this talk. There's a vein that kind of highlights the interval. We kind of find that interval, split it open, and we get down to this kind of view here. The finger here is palpating this nerve called the axillary nerve. That's something we have to be aware of. We have to protect it throughout the case. That's at risk. Behind this finger is this tendon here called the biceps tendon. We find that kind of lets us enter into the joint. And then critically is this tendon here called the subscapularis. And I say critically because we have a couple things have to happen here. For us to get into that shoulder, we actually have to detach this subscapularis. And the subscapularis is one of your 4 main rotator cuff tendons. In fact, it's probably the most important rotator cuff tendon. So we detach that tendon, and then on our way back out, once we've done the replacement and removed the arthritis and put the prosthesis in there, we've got to repair that. And that's critically important for that to heal. And so our rehab after surgery is going to be based on that subscapularis healing. So we'll talk a little bit more about that. So after we've kind of taken down the subscapularis, that's what these little green stitches are in the tendon here. That's the subscapularis. Here's our arthritic bone. We're going to go ahead and find the canal. We remove that arthritic bone. Then we have these we call broaches. And basically you can see these little jagged edges to the side here. Basically this cuts out the bone to shape of the prosthesis that we're going to put in there. We size it this way. So we have a good fit. So we have multiple different sizes that we can put in to really tailor it to the fit that you have in your own. And everybody's anatomy is a little bit different. Okay. Here we're exposing the socket part, and we put retractors here. This is the socket. And then on the side view here, you can see what we do. We kind of ream it down. This is our little metal reamer that spins really fast and creates a nice smooth plane so that we can put our prosthesis in, which looks like this. And we drill some holes into the socket, and then we mallet this prosthesis down. So this thing is plastic. You can't actually see it. Oftentimes there'll be some metal in these pegs that we can see on the x-ray, but there's no ability to see this part of the prosthesis. And then finally, we have our final product. So we've put our stem down, our humerus that we've prepared. We have our humeral head, and here's our glenoid component. And remember, this is the standard shoulder replacement. The reverse shoulder replacement is very much similar as far as the steps. The only difference is here, we're going to put the socket on this side with a lot of screws into the glenoid. We're going to put the ball on this side with a lot of screws into it to stabilize that part of the prosthesis. And then we put the socket on this side. And then all important, like we talked about, this is the example of the repair of that tendon in the front called the subscapularis. These are all sutures going through that tendon that we're going to reattach on our way out. Super important for the function of the standard shoulder replacement. Interesting enough, in a reverse shoulder replacement, we're less concerned about this. In fact, usually when we're doing a reverse, we don't even repair it because it's not there. It's already torn and gone. So we're less concerned in the reverse shoulder replacement about this tendon because it doesn't require that tendon to be there. And like I said, usually it's not there when we're doing it anyway. All right, complications. We need to talk about this. This is important. As surgeons, we have to counsel our patients when we give them informed consent. This is a really super important part of it. So infection is number one. This is the bacteria, unimportant for you guys, other than the fact that this bacteria likes to live in the axilla or our armpits. So it tends to be very close to our incision. It can be a little difficult to diagnose it. It doesn't come out with this full-on purulent infection. It's very clear. So we're always cognizant of that when we're doing revision surgeries, looking for this. But when we schedule you for surgery at San Antonio, you're going to go through a joint class. They're going to talk about all the things you need to do preoperatively. They're going to give you some special soap that really reduces the bacterial count. It's going to be super important that you do that 3 days before. You kind of wash with a special soap that will reduce that bacterial load, because that's where the infections come from. When we talk about the replacement infections, it always most often comes from the patient's own skin. So we do a lot of things, and if you come to San Antonio, we'll make sure that we kind of reduce that risk. Our numbers are outstanding, fantastic as far as post-operative infections. So we're really careful with that because we know this is so important. I will tell you that if we look at all the data that supports that we look at, infection rates in shoulder arthroplasty are less than 1%. So it does not happen very often, but it is, when it does happen, it's a big deal. It's usually not a simple fix. Could require multiple surgeries to clean out that infection and IV antibiotics. So we really do everything we can to avoid it. Second kind of most common complication from a shoulder replacement is loosening of that glenoid. So that plastic liner on the socket side, there's not a lot of fixation. It's a pretty small area of bone, so that thing can get loose. Like we talked about, that goes back to our patient compliance. If you're doing heavy body lifting or labor and things like that, it's really going to put a lot of stress on that glenoid. It can get loose very quickly and be a problem. Instability, the shoulder dislocating. Don't see that often, but certainly could happen. Subscapularis failure. Remember, that's that rotator cuff tendon that we've peeled off, and then we have to peel back on. We don't see that fail. And then if you have any falls, you can fracture around the prosthesis. These two can be challenging to fix. Here's a little bit of why we think the glenoid fails. So the shoulder, if it's really dynamically stabilized, sitting nicely in the shoulder joint, you can see what we call concentric loading. So everything is loaded quite nicely. You start doing heavy lifting, bench press, overhead presses, you start subluxating that humeral head back, and you get this kind of asymmetric loading. You get rim loading here, this lifts up, and over time you get this kind of what we'll call rocking horse phenomenon, where the humeral head starts rocking back and forth. That leads to early glenoid failure. And here's what it looks like. So here's our glenoid prosthesis we've taken out of a shoulder. You can see over here, this looks pretty good, but down here, it's kind of wasted away to almost nothing. You get loss of that glenoid. So that's what we typically will see. All right. Complications of the reverse shoulder. Instability is probably more common with that reverse shoulder. So here we can see the shoulder is actually dislocated. We try to reduce these closed. Sometimes we have to do a reduce open. If it's found to be really unstable, then we have to do things to increase its stability. Usually that means increasing the size of the plastic insert that will kind of tension everything and keep this thing pretty stable. It's a pretty uncommon, I will say, but certainly is at risk, especially with the reverse shoulder. We can see some stress fractures. It's hard to see up here, but this is something we pay attention to. This is the chromium and the scapula up here. Because we've really changed the dynamics of the shoulder joint and put a lot of tension on the soft tissues, some patients will develop a little bit of a stress fracture. These can typically be handled non-operatively, simple sling, let the stress fracture heal. If the prosthesis becomes loose, then we have to do things surgically. Once again, we can see wear patterns over time. So here, what we worry about is what we call this subspine impingement here. So this impingement of the prosthesis. Over time, you get wearing. The newer prostheses are better designed. They kind of remove some of this as a concern. And so hopefully we won't see any issues with this long-term for most of our patients. And then post-op rehab. So just to go into a little bit as far as, the surgery, we do the surgery at the hospital. Most patients are able to go home post-op day one. We even have patients who go home the same day. It's a great surgery for that. They do an interscaling nerve block, and they really, patients don't have a ton of pain after surgery. Once the nerve block wears off, then there will be some pain. Most of my patients stay the night, but certainly it's a consideration to have them go home the same day. The therapist will show you some exercises that are kind of demonstrated here. It's kind of inline phase or just in front of your shoulder phase only. Especially for the standard shoulder replacement, we really have to be cognizant of that subscapularis tendon. So we don't want to stress that repair. We want to give it a chance to heal. So the therapist will show you some pendulum exercises, some shoulder shrug exercises, but we don't do a lot of aggressive therapy for the first 4 weeks. After 4 weeks, we get you out of the sling that we put you in and really start working on range of motion and eventually some strengthening down the road. In the reverse shoulder, we have to be less concerned about some of the subscap issues, the rotator cuff repair issues, because you don't really need that for it to function well. But I oftentimes will keep most of my patients in a sling for about 4 weeks, mostly just to let the soft tissue envelope get used to this new prosthesis. It really does change the dynamics of the shoulder. You're putting tension on muscles that haven't normally been tensioned that way. And so I find that most of my patients, they do better from a pain control stance, from being kind of immobilized in that sling, letting the soft tissue envelope really get adjusted to this new shoulder, and then get them to therapy after that. Okay, so that's the entirety of my talk. Hopefully they've generated a few questions here we can go over. I'm happy to answer any. And thank you for listening to me. I hope you guys got some good information. Like I said, let me reiterate what, if you guys didn't hear the beginning part, San Antonio's done a really wonderful job with the joints program, working with the surgeons, the nurses, physical therapy, the admin staff to really create a great program for you patients. Hopefully making it a smooth, seamless process, answering questions, getting family involved, and doing a great job with the surgery, limiting the risk factors. So it really is a fantastic place. I love sending my patients there because I know they'll be well taken care of. So thank you guys for listening, and then we'll answer a few questions. I can't hear you guys. Are you guys saying anything?
Sorry about that. We were on mute.
All
What I said
right.
was, what a wonderful presentation.
And we agree.
It was fantastic. So there were a few questions and Kathleen did answer it, but we would love for you to elaborate on that.
Sure.
Alice asked, what can I do to improve the results of the surgery? Do I need to lose weight and stop smoking?
So good questions. And the answer to both of those questions is yes, especially the smoking. Why smoking? Well, smoking, what it does to the blood supply to everywhere in the body is it kind of causes the smaller vessels to kind of constrict a little bit. And so, we need, when we're healing a wound, when we're healing a tendon repair, we need a robust blood supply to kind of bring all the things that kind of allow the body to heal. And so smoking is absolutely kind of contraindicated for an elective surgery like a shoulder replacement. If we have a fracture, if we have something we need to do surgery on because it's an acute thing, then sometimes we can't get around it. But if we're doing something elective, it is much, much, much more preferable to quit that smoking, which I know can be a real challenge for a lot of our patients. But it really is beneficial as far as healing of the wound and healing of that tendon repair and all the soft tissue things that go into it. As far as the weight loss is concerned, absolutely, weight loss is important. It's probably less of a concern in shoulder arthroplasty compared to total hip and total knee arthroplasty, where it's really been found to be a significant problem. So, but certainly I counsel all my patients who are overweight, weight loss before surgery is critical. There's some patients that are morbidly obese that we say, listen, we set target goals for weight loss and say, listen, you have to hit this goal before we can consider surgery on. And lo and behold, a lot of those patients will be able to do that, and that benefits not just from the surgical standpoint, but that benefits their whole lifestyle. So the answer to both of those in short are yes, but really the smoking cessation is super important.
Another question was, what is the joint replacement piece made of? Metal or plastic, or both?
It's both. So the humeral side, so the side where the ball is made out of metal, and that's a titanium primarily. There's also cobalt in there, but it's mostly made out of titanium. The liner side is made out of the fancy term is polyethylene, but it really is just a plastic liner. And a lot of research goes into kind of what are the best kind of articulations for the shoulder. The metal and the plastic liner are probably the two best and two most commonly used. If there's a hip replacement talk, there'll be other kind of prostheses, other components that they use are made out of something different. So you can maybe hear a little bit more about that. For the shoulder, it's a metal and a plastic replacement.
Arlene asked, do you have orthopedic? Did I say that correct?
Yeah, do you do Orthovisic injections in the shoulder?
Yeah, so the Orthovisic, that is a hyaluronic acid. So we did talk about that. And Orthovisic that's just one of the named hyaluronic acids. There's several on the market. We can try. The issue is that really all the studies on hyaluronic acid, Orthovisic included, were done on the knee. So the FDA approved them for knee injections. They really weren't done for the shoulder or shoulder arthritis. It's the same pathology, so it makes sense to try to be able to use them. The issue becomes is when we ask for it, the insurance companies like to deny it and say, well, it's not indicated for the shoulder. So it depends a little bit on the insurance company. But I have done it in the past, and it does work for a lot of patients, temporary. It's not going to get rid of the arthritis, but certainly, like we talked about, we do like to do a lot of non-operative treatment before we dive into the arthroplasty or the shoulder replacement.
Fantastic. And she also asked approximately how many inches is a shoulder replacement anterior incision or scar?
A little bit depends on the patient and the body habitus, but in general, I would say you could talk about, I would say 6 inches is probably 10 centimeters to 10 centimeters, 6 inches is probably the size. Thinner patients, we can do a little bit smaller incision. Larger patients, the incision's a little bit larger. What I would say is the size of the incision doesn't matter much. It's our ability to get inside the shoulder and see everything and do everything well is the most important thing. That's what will end up with the best result. So if we need to make a longer incision, we do in order to give us access so we can do the best job possible.
And Alice also asked, how long will it take her to fully use her shoulder? However, I think this is more like kind of specific. So let's do a general here. How long does it take typically for them to get full use of their shoulder?
No,
And
it's a good question as far as the rehab is concerned. So, and I'll go a little bit more into the timeline. So shoulder replacements, I usually have most of my patients in a sling for the first 4 weeks. Then they will initiate physical therapy at that time. And the first 2 months of therapy are really to regain the range of motion or to maximize the range of motion in the shoulder. So that puts us at the 3-month mark. And then the next 3 months are really all about strengthening. And so I tell most of my patients they'll have most of their function back that they're going to gain after the surgery at 6 months. And really at 1 year, that's kind of where we see the maximum amount of improvement. So at 1 year going forward, that's kind of what the shoulder is going to look like. Now that gives everybody a little bit of pause because that seems like a long time, and it is a long time. But I will tell you that the overwhelming majority of patients, by 2 weeks after surgery, the arthritic pain is gone. So they may have some post-surgical pain, but the arthritis pain that they were experiencing before surgery is pretty much gone by 2 weeks to 4 weeks. So they like that a lot.
that's amazing. Well, another question from Bill is there an upper age limit?
No, there's not an upper age limit. Certainly, it's more going to be based on other medical issues. So if for example, and Bill, I don't know how old you are, but if you're a 90-year-old who is rock solid, stable, has no medical history, no cardiac history, no diabetes, everything is really great, and the only thing you're complaining about is shoulder pain that's really dysfunctional for you, meaning it affects your daily activities, prevents you from sleeping, prevents you from doing the things you like to do, then no, you would be a candidate for it. I also have 55-year-olds who have end-stage renal disease, bad coronary disease, who have multiple comorbidities and really aren't safe to undergo a big surgery like this, that they're not a candidate. So there is no strict number cutoff where we say you're too old or too young. It really varies based on each patient. I will say the overwhelming majority of total shoulders that are done by me and my partners and everybody else at San Antonio is probably in the age group between 60 and 70 years old. That's the most common. But like I said, you'll see 50-year-olds, you'll see 80-year-olds. Less common, but certainly there's no strict criteria for cutoff.
As I said earlier, I found your discussion very interesting, and you did talk about something about reverse shoulder. Is that a new procedure?
Newer in the sense that the standard or the regular shoulder replacement, which is what is done kind of most commonly, although it's about 50-50 now. But we've been doing the reverse shoulder replacement for over 15 years now. And I will tell you in the last 10 years, the last decade, it's become more and more common, and to the point now in the United States where if we talk about shoulder replacement, 50% are going to be the reverse and 50% are going to be the standard or the traditional shoulder replacement. So it's relatively new, but it's not that new anymore. And certainly it has a lot of good use and good functions, and it helps us treat a lot of patient pathology that we had a hard time treating before. So that's why it's become such a popular thing, because it really does help us with dealing with some of the issues that we see with the shoulder.
So how would you know if you're a candidate for reverse shoulder?
Well, that would be a discussion you have with the surgeon in the office. So they have to get x-rays and evaluate you. Like I said, there may be other imaging studies like MRI or CT scan that also help make that decision. And really it's a decision that, or you have to go, the surgeon has to look at it. So it's, you don't know if you're a candidate for a shoulder replacement or a reverse shoulder replacement until you go in and talk to an orthopedic surgeon. That's a discussion. Primary care doctors likely aren't going to understand the nuance, the nature between the two. Physical therapists really, unless they treat a lot of shoulder patients, aren't going to necessarily know the nuance difference. That's something that your surgeon has to kind of review with you and go over the indications and why they're thinking one way or the other.
Awesome. So we were talking about like weightlifting, and I was kind of having a discussion over here with Kathleen. And let's just say because I had a question regarding the wear and tear of the shoulder. So I know you said you're not supposed to do any exercise overhead, but is it period, or is there such thing as lightly or moderate?
For sure. So, and a good question and a challenging question. So I do have a lot of active 70-year-olds who work out on a daily basis who have bad shoulder arthritis. And so what I generally tell them is that it's not as if you cannot be a weightlifter or you can't do any overhead activities. It's just we have to really curtail the weights and how strenuous the weights are. So I kind of tell them, listen, lower weights, higher volume, really good form, good reps are more critical. It's the heavy weights that seem to be a real problem, bad form, things like that. So I don't want to say that you can't do anything. And certainly I trust me, I know that I have patients who kind of push the limits and do well with it. But we have to, as surgeons, we have to be cognizant not just of today, but of some of the long-term consequences. So we have to kind of give our patients the information so they make good decisions. But no, it's not that you can't do anything. And there are specific things I go over with my patients, in the office, showing them things. Well, these are things that you can do, but heavy bench press, heavy overhead press, military press, these sorts of things that a lot of patients like to do these days are probably not the best for my patients with a shoulder replacement. So, but it's not, we just have to modify.
Wow, that's fantastic. We do have about 5 minutes left. So if there's any last minute questions that anybody has on their mind, right now is the time to definitely ask. This was such a great informative lecture.
Very good.
Kathleen, is there, can you share how to contact Dr. LaRose?
Yes, if you are interested in talking to Dr. LaRose, making an appointment with him, you can contact him in his Rancho Cucamonga office of Arrowhead Orthopedics. The phone number there is 909-912-1750.
So I could definitely put that in the chat for everybody to get that number. It's 909-912-1750. So it's on the chat. So if any of you have any questions or need to make an appointment with Dr. LaRose, that is the contact number to make your appointment.
Yeah, and thank you everybody for listening. Hope you guys tune in to some of the other talks. I know they'll be really good as well, and really informative, and hopefully give you guys a better understanding kind of some of the orthopedic issues that we see with many of our patients, and you guys will find that you'll have some of these same issues. So, and we have a lot of great solutions, both operative and non-operative. So yeah, please tune in. And if there's any issues, give our office a call, and we're happy to see you and take care of you.
Thank you, Dr. Rose. It was very informative and very interesting, and we really appreciate the time that you took to talk to us tonight.
No problem. Thank you for having me, guys. I appreciate it.
Well, thank you for everyone for joining on today's virtual lecture. We're ending just a few minutes early, but it was a pleasure meeting